And what type of facility is that?
It's a subacute rehab facility.
Please elaborate on that. What do you mean by subacute?
So these are patients that most likely came from an acute care hospital. For example, Bridgeport Hospital or St. Vincent's Hospital. Part of the building is a long-term care facility, so there's 360 beds in the building, but about 30 to 40 of them are subacute patients, meaning those patients are going to get better and then return back to home or their previous level of function.
Okay. Can you just describe to the audience just a quick overview of what an occupational therapist actually does?
Well, an occupational therapist works with patients on helping them return to their daily level of function. For example, we work on activities of daily living, so helping a patient, for example, with a hip replacement, learning how to dress themselves or wash themselves again, or a stroke patient learning how to feed themselves again if they had a stroke on their affected side, so learning how to use the opposite extremity.
Okay.
Yeah.
How do you handle individual differences among clients? For example, some individual differences being some varying abilities that people have, or skills, body types, physiological factors, learning styles, motivational factors. How do you handle some of these different factors amongst your individual clients?
Well, it's very important to be client focused, learning how to learning the patient's specific abilities. So upon eval, when we evaluate a patient on their first day, we ask certain questions about their previous level of function, where they lived before, any problems with their extremities. You really learn personality types, especially determine how you teach someone or how they learn. Also, in our population, mostly being geriatrics, dementia and memory play a big part in how we teach someone.
Okay.
To answer the question.
Motor learning is defined as changes that are associated with practice and experience in internal processes that determine a person's capabilities for producing motor skill. I know that was tough. Motor performance is defined as observable production of voluntary actions or motor skills. So essentially the performance aspect is what is observed, and the motor learning aspect is it's really not seen, but it's inferred. So in your specific field of work, how do you distinguish between the two in terms of what you do?
I'll use the example of the hip replacement patient. So as I get that question, I would use the motor learning part as someone learning how to use adaptive equipment to dress again. So after a hip replacement, there's a lot of certain things you can't do: bending past 90 degrees, twisting your hips, crossing your legs. So someone who typically their whole life for the past 70 years has bent down to pull their pants up now has to learn a new way of dressing and bathing. So I established motor learning as learning the new task at hand, and then motor performance is how they perform the task. So say after a week of teaching them how to dress again and then having them perform it on their own and me observing.
Okay. Speaking of motor learning, what motor learning challenges do you face being a motor skill practitioner? Examples could be practice time, individual differences, skill levels, learning styles, and teaching styles. So what motor learning challenges do you face when you're working with your individual clients?
I think the number one is the cognition plays a huge part in relearning activity. To teach someone, it's like someone that's been doing something for so many years, something new, they usually, that population, the older population, doesn't like to change. So motivation, cognition, what else plays a huge part? Just getting them to learn a new task is very difficult. I don't know if you want to repeat part of that question. I didn't really answer it.
I think you did a good job in answering it. Which source of sensory information do your clients depend on the most? Okay, some specific types would be proprioception, which is one. We have exteroception, kinesthetics, and interoception. Do you know those offhand at all?
Can you define exteroception?
Exteroception is basically sensory from the outside of the body. Proprioception would be sensory from the inside of the body that signals limb and body positioning and movement. And kinesthetics, sensory from the motor system that signals contraction and limb movement.
And what was the last one?
Interoception is also a type of sensory from inside the body. I think, talking earlier, I think we kind of mentioned proprio and kinesthetics as two of the major kind of forms of sensory information. I mean, it would make sense considering you're working with, people that, need to kind of relearn their body and limb movement.
It depends on the diagnosis. So if there's a stroke patient, a lot of them have post-stroke trouble with proprioception. So I think depending on the patient would be the one that you use the most. So with a stroke patient who had trouble with their proprioception, I would use more exteroception,
Yep.
like from outside the body, because their body internally is not relearning movements, so you need to use external motivation or externalception for someone that is a pretty with it, for lack of better words, fracture or femur fracture, I might use kinesthetics.
Yep.
So outside of the body, or movements that are pretty much that person has already learned in their life.
Okay. How do you evaluate whether learning has taken place? We'll do this in certain areas. One, in the area of knowledge of concepts. Okay, so we're talking about understanding, rules or strategies and the selection of appropriate actions. So in your case, obviously, the everyday things that you're kind of retraining your clients. So how do you evaluate how they're learning in terms of how they know what they're doing, their knowledge of what you're trying to teach them?
So on day one, after they leave the hospital and come to us, we do our initial evaluation. So say a person could stand to get on the toilet with, we do it by min assist, mod assist, or maximum assistance. So say they need a maximum assistance of one person to sit to stand, and they needed maximum verbal cues for hand placement, for safety. I would evaluate by the next week. We do weekly notes or updates on them for the doctor. So I would evaluate their knowledge of learning depending on how many verbal cues they needed the next week. So hopefully it goes from max verbal cues to either moderate or minimal verbal cues.
Okay. In the area of control and coordination, so basically flow and quality of the movements that they're doing.
I mean, that's mostly done by observation. So depending on evaluation date to the next week, observing their movement and taking note of any changes.
All right, so similar, I would assume in the area of the muscles used. So any changes in muscle patterns, and would that be kind of similar to the control and coordination, or would you have another means of assessing them?
We do have another means of assessing by manual muscle testing. So there's manual muscle grades. We rate the muscle strength by, it's on a scale of 0 to 5. So it's against a isometric contraction. You rate how much the patient's doing.
Okay, and lastly, in the area of movement efficiency, so we're talking about basically energy costs decreases with practice. So basically, the easier and the more fluid the movement, the less energy that your client is kind of expending. So, how do you kind of evaluate, how well they're doing with that? Is that more of an observable thing?
I would say that would typically a lot of our patients are either on oxygen or just even in the older population, their saturation of oxygen in their blood is lower. So we monitor all the time blood pressure, heart rate, and their oxygen saturation. So I think that would have to do with how well they're expending energy.
So do you have a dog?
I would say the O2 stat is the most one of the best way of monitoring that.
And what's your dog's name?
This is Rocky.
Hi, Rocky. Okay, how do you use demonstrations with your clients? All right, and do you do the majority of the demonstrations?
When learning a new skill?
Yes.
Yes.
When you want your patients or clients to do something, do you kind of demonstrate yourselves, or do you have more? You might have an experience, maybe client show the other client.
No, I would say we always demonstrate ourselves the first time, and then sometimes even put hand on hand. A lot of the times what you have to do is actually put their arms or legs through that movement to teach them.
Okay, what impact does prior knowledge or experience with skills have on learning?
A lot. So I'll bring it back again to the hip replacement. So say it's their second hip replacement. Obviously learning the adaptive equipment and following all the precautions is going to be 10 times easier than someone that has gotten dressed the same way for the last 60 years and has to learn it for the first time. So I think knowledge of doing it before a year ago, 3 years ago, compared to someone who's never done it before, it makes a huge difference.
Okay. Which type of learning transfer do you see the most in your field? All right. Some are classified. We have zero transfer, which are, two skills are completely unrelated. Positive transfer, where past experience helps the learning of a new skill. And negative transfer, where the past experience hinders the learning of new skills. But that's usually temporary and it can be overcome with practice.
Mm-hmm.
So, kind of restating the question, what type of these learning transfers do you see the most when you're working with your clients?
I would say the negative transfer, but
Okay.
but like you said, through practice, they can learn. But I mean, because of the population again, the negative transfer comes up so much because these people are, because their cognition, because they're older. But like you said, I mean, they're there typically 3 to 4 weeks, 4 to 6 weeks, depending on diagnosis, and then they learn how to adapt their lifestyle to.
And I would assume, relating it to the question before, the positive transfer would help a person who's had a knee replacement, before in their lives,
Yeah.
right? Because of the
They
way
know
that
what to expect, yeah.
Okay. What is your least favorite skill to teach?
I'm going to say feeding, only because feeding seems like something so simple and like you've learned since you were a child, and to teach someone that's 80, 85 to feed themselves again, it's difficult, especially when even to teach someone to use their opposite hand to feed themselves. I mean, you see a lot of frustration, you see a lot of disappointment in patients when they're trying to learn how to feed themselves again. So I'd say that